Good morning, everyone. Today, this is our second case review series. As you all know, this is a new series in our YouTube channel. And today we're going to talk about severe erosion. So first, I always like to start thanking, the companies that make these free case reviews possible. And these are Colteen, Oral Arts Dental Laboratories, and Romero Dental Seminars. I also like to remind everyone that always to visit our webpage, www.romerodentalseminars.com. There's a lot of good information in our webpage. We have, when we are working on live hands-on events, we always post them in our webpage. So it's always good that you subscribe to our webpage, which is 100% free, and you will get emails and you will get reminders of whenever some of our activities will be going on live in different cities in the United States. So keep it in mind, and hopefully you can visit our webpage, and again, you can subscribe to it as well. And also, we like to remind our followers to subscribe to our YouTube channel. Right now, we have over 100 videos for continuing dental education, free continuing dental education in our YouTube channel. So please visit our YouTube channel, share it with other colleagues, but most importantly, subscribe and just, pick and choose. There's a lot of topics. There's a lot of good information there that you can apply in your daily practice immediately. So hopefully you take advantage of that, and you can visit us and again, subscribe to our channel. So let's get started with our case review of today. The first thing I want to share with you is this patient came to my practice. She was really not aware of the erosion going on her dentition. She was there only for a hygiene appointment and a recall appointment. And it wasn't until I approached her and looked at her smile and took this initial photo where you can see not only the erosion on the facial aspect of both of her teeth, 8 and 9, and also a little bit on the gingival aspect, cervical aspect of 7 and 10, but most importantly, the attrition at this point present in 8 and 9. So I asked her about this attrition, and she was very adamant to say that she had noticed that her teeth, had started to chip on these incisal edges maybe a couple of years back. She didn't know why this was happening, but I just brought it up and I said, look, let me just do a little bit more of an in-depth exam, and then we'll start talking about what may be the causing factor, and most importantly, what can we do to try to help you solve this problem. Again, if you look at these photos on the left-hand side, you can see again that shiny area, that erosive enamel area on the mesial cervical aspect of both 8 and 9. You can see there's a little ditch or a little depression on the facial of 8 and 9. But if you look at the photo on the right-hand side, you can now not only see the attrition on both incisal edges, and this is a very common finding when you have patients with severe erosion, because this severe erosion not only affects the facial aspect. This is literally telling us that something is coming from the outside to the inside of her mouth. But you can see that, the more the pH is higher in her, the more the pH is lower in her mouth, the higher the acidity. You're going to find that she's going to just, the patients are going to just literally wash away the enamel from the lingual side of these teeth, what makes them more prone to these type of fractures, these type of attrition effects on the incisal edges. And this is due obviously to the increased flexibility of the teeth on the lingual, because there's no enamel left, there's only dentin, but still remaining some rigidity of that enamel on the facial, which actually starts fracturing the incisal edge because of the lack of support. Now, I also want you to look on the right-hand side, the photos of the mandibular incisors, all 4 mandibular incisors. And I want you to look at the cervical aspect. You can see how thin the enamel is. There's a lot of translucency there, but not only that translucency, you can also see a little margin, a little area like a prepped margin on the cervical aspect of all those 4 incisors. And that is also, an indication that erosion, that the enamel is being washed away from an acidic environment, and that, these are the consequences of what you're seeing. Now, normally patients, they can tell that their teeth are fracturing. They have these little fractures on the incisal edges, but they're not aware of what's going on. So this is our responsibility as clinicians to make them, become aware of what's going on, and just to have this conversation with them, because there has to be something in their diet that they're doing at this point to allow this type of erosive pattern to happen and to progress over the years. And that's, that 100% sure of that. Now, again, let's look at same patient, occlusal view of the maxillary arch on the left-hand side, occlusal view of the mandibular arch on the right-hand side. I want you to look at the left-hand photo. You can see no enamel on the lingual of 7, 8, 9, and 10. Very little enamel left on 6 and 11. No cingulum. So the cingulum has been completely eliminated, completely flat lingual surfaces for all these 6 anterior teeth. A lot of yellow, a lot of dentin exposed, very, very little enamel. And again, this margin, this kind of like prepared margin on the lingual side. And this is typical of the erosion of the erosive factor. And there's a reason for that. The closer the enamel is to the gingival margin, this gingival margin is covering the enamel in that area, is protecting the enamel from that acidic environment. But the further away you are from that gingival margin, the more exposed the enamel is to the oral environment, to the actual acidity of the oral environment. And that's where you just literally wash away that enamel. At this point, you can see that the mandibular incisors, the incisal edges, because again, there's a compensation factor. Patient is losing vertical dimension because they're losing enamel. This loss of enamel is progressive. It's kind of like slow, but progressive. So it allows the teeth to compensate for this, to over erupt, compensate, and just maintain or sustain that the actual vertical dimension of the patient. But this at the same time, on the same token, it maintains this contact between the incisal edges of the mandibular incisors and the lingual erosive surfaces of the maxillary incisors. So there's really no space for you to restore. If you think about it, the only way, if you look at this case, the only way that you can, kind of, the thought process would be, how can I restore this case? You would have to either increase the vertical dimension, or you would have to prep all these teeth and put full coverage crowns on all this patient's teeth. Now, when you think about that, when you think about the treatment options for these cases, I want you to stop for a minute and think about it, because if you already have eliminated enamel on the lingual surface, that means that there is no more DEJ, and now you prep these teeth for crowns. Can you imagine the amount of reduction you're going to have to accomplish on the lingual side so that you can create clearance for the restorations? Most likely these teeth are going to end up having, end up having root canals, and these root canals are only going to be there just because you don't have room for restorations. So if you think about it, the only other option that you're going to have is increasing vertical dimension. Now, the question is, why would you increase vertical dimension? And the answer to that question is very simple. Look at the mandibular molars and premolars and the maxillary molars and premolars. All the enamel has been washed away from that occlusal surface. You can literally see how much of the dentin is exposed at this point. So again, we know that we've lost vertical dimension. We've lost enamel. We have compensated with over eruption of the teeth for the loss of the vertical, but we have lost that enamel. And at this point, all these teeth are occluding on that dentin surface. So the only option that we have is to increase vertical dimension so that there is no reduction. We don't have to, put these teeth under any more reduction of the enamel or dentin, because at this point they've prepared, quote unquote, themselves through this erosive factor and attrition. So again, think about it. Think about that mechanical way of restoring this case by increasing vertical dimension, and that's literally what brought this case review to today's lecture. And again, that's kind of like the path that we are going to follow with this specific case. So I want to bring you again into the evidence, into what the literature says. In 2010, Dr. Francesca Valati published this nice classification, and her team published this nice classification called the ACE classification, which is a classification for anterior maxillary dentition affected by dental erosion. And the beauty of this, if you look at this chart, there's 6 different groups. I'm not going to go over all 6 groups. I'm going to just go over the first 3, because our patient today is a class 3 patient, is an ACE classification 3. But I want you can Google this article, you can download it, you can read it, and there's multiple articles written by this group and other groups that are around this same topic that I would highly recommend you review, because it's going to help you understand more the process of how do you restore these cases. But again, if you look at the ACE classification 1, you're seeing that there's already initial signs of erosion, which is a little shiny surface a little bit of lack of enamel or erosion of the enamel on the cingulum of anterior teeth of centrals, laterals, and central laterals and canines, and mainly on the centrals and laterals. And when you see that enamel that has been eroded away, and you see this shiny surface on the lingual aspect of your patients, you're not going to see any attrition on the incisal edges, most likely because you have an intact lingual fossa and you have an intact enamel on the incisal edge. So at this point, you're only going to see that shiny surface on the cervical portion of the lingual aspect of these teeth. But this should catch your attention when you're doing these periodic exams. Please look at this, and mainly on young patients, because these young patients are the ones that are doing multiple sport activities. They're the ones ingesting or drinking these low pH, power drinks, if you want to call them that way, or healthy drinks, quote unquote. And again, the reason is they may be healthy for other reasons, but they're definitely not healthy for our oral environment. They're definitely not healthy for our enamel. So when you see these patients, and you see this type of erosion, talk to them, ask them, what does their diet look like? Are they having any energy drinks? Review what kind of pH these energy drinks have. I'll show you the one that my patient was drinking, and we'll talk a little bit about that pH and why she got to the point that she is at this point, that she is at this moment. But I want you to now go from ACE classification 1 to ACE classification 2. Again, a little more erosion of the lingual enamel, mainly on the lingual fossa. And then if you jump to the ACE classification 3, you now have complete enamel erosion from the gingival all the way down to the incisal edge. At this point, you have more dentin exposed on the lingual, still some shell of enamel on the facial, more flexibility of these teeth. The incisal edge starts to fracture, attrition comes into play, and you have less than 2 millimeters of incisal edge wear. This is where my patient is. This is where ACE classification now requires a restoration. And what treatment recommendation they have? Well, for class 2, they have, either direct or indirect composite restorations. That's what I would recommend. For class 1, you see they have no treatment or no restorative treatment recommended, just a follow-up and for sure changing or modification of the diet. But when you get to ACE classification 3, you see now that they have lingual veneers where you're restoring not only the lingual missing enamel, but also the incisal edge. And this is exactly where my patient is. Now, I want you to think about it. If you're going to add lingual, either composite, direct or indirect, or ceramic on the lingual aspect of these anterior teeth, you're going to have to definitely increase vertical dimension, because the idea is that there is no added reduction. There is no room for you to do more tooth reduction in order for you to restore this case. So this is an additive case, and that's exactly what the ACE classification and the three-step technique, described by Dr. Valati, that we're also going to share with you, is all about. Now, just to show you some case examples, this is literally directly from Dr. Valati's article. You can see the ACE classification 2, and I want you to see from left to right. You can see that on the left-hand side, there's minor incisal edge wear. There is no attrition on these teeth. But if you look at the middle photo, you can see now that there is literally like a step. Like this step was created by the relationship between the incisal edge of the mandibular incisors and the lingual surface of the maxillary incisors. Literally, these mandibular incisors are breaking off because the acid has weakened the enamel. So every time that this patient is biting into central relation, they're literally chipping off that enamel and creating this positive stop, this little step on the lingual side, on the lingual surface of 8 and 9. If you think about it right now, that incisal edge is literally touching that step that you're seeing on that middle photo. So again, if you go to the photo on the far right-hand side, you see that these teeth have been restored. All 4 incisors and canines have been restored with lingual composite restorations, lingual veneers, in other words. And these lingual veneers are now at a new vertical dimension. So yes, this patient not only needs to have these anterior teeth restored, but also is going to need the posterior teeth restored so that we can accomplish full occlusal contact throughout both arches. And that's just one way of doing things. I'll share with you a different concept that you can also use for these cases. But this is a great example, same from directly from this article, for an ACE classification 3. Now, this is kind of like what my patient presented with. You can see on the left-hand side, the upper photo, this is the initial situation, collapse. You can see a deep overbite, collapse of that vertical dimension, loss completely of the lingual enamel, dentin completely exposed. from canine to canine. You can also see loss of enamel on the occlusal surfaces of premolars on these photos, and I'm sure that it was all the way back to the molars, just like my case. So you can see now this patient has been eroding his enamel for years, most likely again due to many circumstances, due to a low pH on their diet, to either soft drinks, or I have found even patients using mouth rinses that have bleaching quote unquote potential with very with very low pH and very abrasive possibilities, or either with the toothpaste or with the mouth rinse. So again, think about it and talk to your patients, because many times we have to make sure that they eliminate the causing factor so that our treatment really lasts a long time. It's really functional, or it does something really for them. So on the right hand side, the same case, you can see that they've done lingual veneers from canine to canine. You can see the lingual veneers there. Also occlusal veneers on the premolars and molars to establish a new vertical dimension. You can see that they decrease the deep overbite by a couple of millimeters by increasing vertical dimension. And this helps because it helps for better anterior guidance and left and right canine guidance and posterior disocclusion. So we're only trying to help our patients, and we're trying to help them with a conservative approach to their excessive wear, because again, the only other option you have is to prep all these teeth for crowns, and you're going to have to most likely devitalize all these teeth, and not to mention the weakening of the actual structure by eliminating the remainder DEJ on the facial aspect of these teeth once you prep them. So again, we're back to my case. You can see now why I said that this case is an ACE classification 3. She's got less than 2 millimeters of incisal edge fracture or loss. But again, look at the lingual surfaces of all anterior teeth and occlusal surfaces of all posterior teeth, where it's very noticeable that there's been an aggressive erosion pattern. What was included in my patient's diet? She was taking specifically this product that you see here on my screen. It's called Kumbacha. Before I met this patient and I spoke to her about this, I had never heard of this drink before. This is supposed to be a cleansing solution. It's supposed to be one of these miracle solutions that you drink and it does help you for everything. Well, guess what? One of the things that this company does not let their customers know is that the pH of this drink is between 2.5 and 3.5, when we know that enamel only withstands up to 5, the lowest is 5.5, I'm sorry, 4.5 pH. So we know that anything below 4.5 is literally just going to wash that enamel. And dentin is even weaker. Dentin cannot withstand a pH lower than 5.5. So think about this. We have a very low pH and very acidic solution that our patients are drinking. And obviously she was drinking 1 or 2 of these a day. So she was sipping on this all day long. She would never give her mouth the opportunity to buffer this solution and get back to a normal pH. So, to a more basic pH. And that's really the critical aspect. And I have had patients like this that either have Gatorade or have any other of these soft power energy drinks. There's some of them even called, waters with flavors that have a very low pH. I've had patients that use abrasive toothpaste in combination with bleaching potential mouth rinses that have very low pH, and the toothpaste has very high abrasive pattern. So the combination of these two things, I have seen that also create problems in my patients. And I know that you see these cases every single day also. You see cases with excessive erosion or severe erosion every day in your practice, because this is something very, very common today. And the thing is that we have to make sure that we have this conversation with our patients. And what I'm doing today in my practice is that every time that they come with us, with a drink that I've never heard before, I ask them, do you know what the pH is? 9 out of 10 times the answer is no. If not 10 out of 10, the answer is no. I don't even know what pH is all about. I go ahead and Google the pH and you get this right there. This was the answer to this particular drink that she was taking. And now we know why she presented in the way that she did to my practice. So again, one of the treatment options that Dr. Valati and her team came up with, which I think it's a great solution, is called the 3-step technique. I honestly, do a little combination of the 3-step technique with the doll effect, and I'll talk a little bit about the doll effect shortly. But I do want to mention this 3-step technique, and I want to kind of walk you through. Again, there's an article written by Dr. Valati and her team about this 3-step technique. You can download it directly from Google. But the most important thing is that it's divided in 3 different steps. And I want to kind of outline and kind of explain what these steps are. Step number one is going to be the occlusal plane assessment, which in essence is really an aesthetic evaluation. You notice that my patient had excessive wear on the incisal edges of 8 and 9, but if you have more severe cases, you will find this, the laterals and the canines and premolars also affected by this excessive wear. The first thing that you have to do is assess that occlusal plane. So if you look at the right-hand side of the chart, the first photo, the one on the top right, the top left-hand side of my screen, I'm sorry, you can see that they've only waxed up the facial aspect from canine to canine, and then the buccal aspect of premolars all the way up to the first molar. Sometimes they stop in the first or second premolar. The idea is that you're going to do then a mock-up with this wax up without including the occlusal surfaces. This way, you're not preventing your patient to literally closing down. All you're doing is just analyzing or evaluating the occlusal plane and the aesthetics of your final restorations. You're answering a couple of questions. Is your incisal edge at the right location? Is this new position of the incisal edge something that would bother this patient? Would it affect the patient's phonetics? Is the canine cusp position the right one, the right position? Can this patient protrude the mandible and disocclude everything on the back with that new incisal edge position? Can this patient move left and right and disocclude left and right working and non-working sides due to, thanks to the canine guidance? These are the questions that you want to answer. That's why you're only doing more of an aesthetic evaluation. Step number two is now posterior support. So now we're saying, okay, in order for me to accomplish this new incisal edge position, I need to increase the vertical dimension by this much. And that's when you establish that new vertical dimension. That's when you do it on your definitive wax up. So right now there's two wax ups. The first one for aesthetic evaluation, the second one now for the occlusal or the increase of the vertical dimension evaluation. And that's the one that you're going to then create some clear matrices with clear PVS so that you can then transport that or transfer that to the patient's mouth and do these restorations directly into the patient's mouth. And step number three is going to be the anterior guidance. So if you look at the wax up on step number two, it only talks about posterior teeth. So this is, if you think about it, when you restore, because the first thing you're going to do is increase vertical dimension. And for that, you're going to restore premolars and molars. Your patient is going to have an anterior open bite for 4 to 6 weeks, depending on the time that you want to try this new vertical dimension. And there's a reason for that. Clinically, it's a lot easier to just adjust, 3 or 4 teeth on the upper and 6 or 8 teeth on the upper and 6 or 8 teeth on the lower. I normally just wax up all the way to the first molar, just like you're seeing on this case. I leave the second molars without any wax up. It's a lot easier for me to just adjust between 6 teeth on the upper and 6 teeth on the lower. And all I have to do is make sure that when they're tapping open and closing, there's simultaneous contacts on the functional cusp, marginal ridges, and central fossas of these opposing teeth. And that's all I have to do. Now, because my patient doesn't have any restorations on the anterior guidance, of course, I don't have anything to adjust on these front teeth. I'm going to wait 4 to 6 weeks in order for me to then go ahead and restore this anterior guidance. So that's when it comes down to this another article that I want to share with you. And this was published in 1975 by Dr. Bjarne Dahl, and it's called the Dahl effect. Now, the Dahl effect, like the article says, it's an alternative treatment option in cases with advanced localized attrition. So in other words, what Dr. Dahl was seeking was a way of treating patients that had excessive attrition, excessive wear, for whatever reason, missing teeth, clenching or grinding, whatever reason. And now he wanted to increase vertical dimension, but segmentally increase vertical dimension, and then allow the rest of the teeth to over erupt and then accomplish or achieve full interocclusal contacts between both arches. That is the idea behind this. And I love this idea because not only that it works and it's a really good way of treating patients of, like the case that I'm sharing with you today, but even if you were to do the Volati technique, just exactly the way that she has it, I want you to know that if you keep these patients 4 to 6 weeks with your posterior prototypes, the elevator muscles are going to, their fibers are going to be overstretched because you're literally increasing vertical dimension. And how are they going to respond to that? They're going to respond by contraction. And that contraction is going to do two things. It's going to create excessive pressure on these posterior teeth, and it's going to now remodel the alveolar processes around these teeth, creating a little bit of intrusion of these teeth. At the same time, the teeth that are not in contact are going to extrude because that's what they're made for. You know, they wanted contact, and they were in contact before you added the composites on the posterior teeth and increase the vertical dimension. So the system is going to compensate on itself. So when you come back 4 to 6 weeks later, and I'll show you that in this case, you will notice that you have less interocclusal space. So honestly, what I do is I remount the cast at that point when I'm going to do my anterior guidance, and then is when I wax up the anterior teeth if I want to use a guide, a matrix guide to restore the anterior guidance. Again, this is just the way I do it. You know, there's multiple ways of doing this. You can follow strictly the Valati concept, or you can combine the Dahl effect and the Valati concept, just like the way that I'm sharing with you right now. And that's exactly how I do it. And I think it is a good way of doing it because I have just had success with this type of approach when I combine both of these philosophies. So just to iterate, you know, what the concept, the Dahl concept is all about, this is directly out of the article. It refers to the relative axial tooth movement that is observed when a localized appliance or localized restorations are placed in supraocclusion and the occlusion reestablished full arch contacts over a period of time. So this is directly from the article, exactly what I just explained to you. And this is what I'm going to share with you for this particular case. Again, if you look at the left-hand photo, you can see that is now increased vertical dimension. So if we've restored premolars and the first molar, upper and lower arches. So you can see on the left-hand side, right now, there is no contact between the upper incisors and the mandibular incisors. And if you look at the photo on the right-hand side, I've asked the patient to raise their chin, and I've taken a photo a little bit more angled so that you can see the distance that I have between the lingual surfaces of the maxillary incisors and the incisal edges of the mandibular incisors. This is telling you the 2 to 3 millimeters of increase of vertical dimension that I needed to do on my articulator in order for me to have room to restore both upper and lower premolars and molars and create stable holding contacts on both sides of the arch. And again, once you do these, I use a matrix. And again, if you read the article or you watch, I have a previous webinar where we were talking about bonded functional aesthetic prototypes and occlusion. We have part 1 and part 2 on my YouTube channel. If you watch those webinars, you will see exactly how I fabricate these clear matrices. But that's what I use to restore the posterior teeth. I'm using, in this particular case, just regular microhybrid composite. You can also use flowable composite, but for cases where I'm doing a full mouth and it's, you know, and I'm going to be waiting 6 to 8 months, I'm sorry, 4 to 6 weeks, I want to make sure that I have a really strong restorative material. And for that, I use just regular composite. In this particular case, I use Brilliant Everglow. That's the #1 composite I use in my office, and it's made by Colteen. And I'll tell you a little bit later why I like using it for cases like this. So you can see that I've restored all posterior teeth. I allow the anterior teeth to be out of occlusion. My patient knows that she's going to have anterior open bite for 4 to 6 weeks. But I also tell them there is no, we don't have any effect on the chewing or masticatory efficiencies, nor on their speech. They're able to, you know, have a good conversation and eat well, even though they have anterior open bite for 4 to 6 weeks. You can see now that after I do these prototypes, I always scan my patient. Just to have that reference, how much was my vertical dimension increased the day that I delivered these posterior restorations? And then I do another scan 4 to 6 weeks later, just to see, okay, how much vertical dimension, how much change was there between day 1 and day, you know, and 6 weeks later in regards to my vertical dimension. So always today you have the scanners, you can do that, and it's really, really helpful. But I want to show you the photos because these speaks volumes of what we're doing or what we're trying to accomplish here. Look at the left-hand side. You can see this is day 1. I restore premolars and molars, increase vertical dimension. You can see the distance between the upper and the lower arches. And on the right-hand side, this is 6 weeks post-op after placing my posterior bonded functional aesthetic prototype. You can see that there's been at least 1 millimeter to 1.5 millimeters of intrusion and extrusion of teeth in order for them to compensate. And this is what the Dahl effect is about. Okay, so you're closing, and that's, you know, because there's going to be intrusion and extrusion because you're allowing the muscles to do their thing for 4 to 6 weeks. this is what's going to change. And this is what the Dahl effect is all about. That's the reason why I like combining the velocity technique and the Dahl effect on cases like this. And again, a little close-up photo, you can see on the left-hand side, again, day one of my bonded functional aesthetic prototypes at a new vertical dimension on all posterior teeth, and the distance during the first day and the vertical dimension distance between upper and mandibular incisors 6 weeks later. You can see the difference, at least 1.5 millimeters. So there's a lot less that I need to add to the lingual surfaces of the maxillary incisors in order for me to accomplish contacts. And that's what I did. 8 or 10 weeks later, so I allowed 4 more weeks. 10 weeks later, I went ahead and did individual lingual composite veneers, direct composite veneers from canine to canine to reestablish anterior guidance and canine guidance on this patient. Now, in this photo on the right-hand side, what I want you to see is the way that the integration between the composite and the actual enamel on the facial aspect of the tooth. You can see that there's a little line where you can see the difference between the composite that I placed, because I went ahead and wrapped the incisal edge because she had lost 1 millimeter approximately, or 1.5 millimeters of her incisal edge. So I went ahead and did these lingual veneers to cover and compensate for the loss of the incisal edges as well. And you can see initially that transition line between the shade of the composite and the enamel. This is only, the shade that I used with her was A1B1. This is only Dentin shade from Brilliant Everglow. Now, Brilliant Everglow is a beautiful system. I like it for highly aesthetic restorations, but it's a simple system. It's not a system that has, hundreds of colors. What it does have is a system called the dual shade system by Coltine, which allows you to use, you have in every compule, you literally have 2 shades. So in this case, I use A2, and A2 is A2 and B2. If you use, so you have these options, and you have 2 shades per compule. So, and there's 8 different shades, but you only have 4 different compules in that kit. But these 4 compules represent 8 shades, and you have 2 enamel shades, a universal enamel and a bleach enamel. So again, very simple way of doing highly aesthetic restorations. That's the reason why I like it. But most importantly, in this particular case, I only use Dentin, and I want you to see what happened 15 days after I've completed my anterior guidance prototypes. You can see that there is no more transition line between the composite and the tooth. It has completely bio-integrated. So really, really good chameleon effect of this composite. You can get really, really good match with this single Dentin shade without using any other enamels. And again, these are definitive restorations. In this particular case, I'm not using it as definitive restorations. We're going to transfer her to more definitive restorations for sure. But what I want you to know is that I'm going to allow her to use these prototypes for a little bit longer, because I want to make sure that there's no clicking or popping of the joints. There is no pain at the level of the TMJs. There's no fractures of any of my restorations, meaning that we have good anterior guidance, good canine guidance, and good posterior support. So we are not only restoring the loss of enamel, but we are also restoring the stomatognathic system and the way that it should work, with anterior guidance, canine guidance, posterior support, simultaneous contacts on the functional cups, marginal regions, and central fossas of our posterior teeth, and obviously our dots on the anterior, on the cingulum of anterior teeth, and then our lines when they come forward for this occlusion. Now, in this particular case, once I restored the lingual aspect of the teeth, I noticed that, if I added more composite, they were just going to be too bulky. So what did I do? I told the patient, we're going to keep this. You can see this on the right-hand side. There's a little bit space left in order for these teeth to come into contact. And I'm just going to allow the system, I'm going to allow the Dahl effect to do its thing, to accomplish full contacts exactly like we did. You notice that we were able to close a little bit on the vertical dimension after 4 to 6 weeks of using the posterior prototypes. We're just going to let the system do its thing. And that's why you want to take one step at a time. That's why you don't want to rush through these cases. I'm going to allow her, I've given her 4 to 6 more weeks. I'm going to see her again in 4 to 6 more weeks. Make sure that everything is now in contact. If I haven't accomplished any more contacts, I'll adjust the occlusion in order for me to achieve full contacts. And then I'm going to start my final restorations. Where are these going to start? They're going to start on the posterior teeth, because I want my anterior teeth these composites that I did from canine to canine, I want them to hold my vertical dimension so I never get lost. And I can actually start restoring the upper arch first and then go to the lower arch. You can do it however you want based out of the finances of your patients. And that's another beautiful thing that Dr. Valati literally states in her article, where she can, she can work these very large cases, but she can separate them by quadrants, meaning that you do more quadrant dentistry, but you're really doing a full mouth case. And I don't want you to get confused, because I know that there's a lot of people out there today, talking not as good as they should be talking about quadrant dentistry. But this type of quadrant dentistry is different, because you are accomplishing full mouth rehabilitation, because you have really good interim restorations while you're delivering your final restoration. So this is just, again, a way of doing things. It's not the only way. I'm 100% sure of that, but I don't think that there's anything wrong doing it, following these steps and following this philosophy. So, I hope that you enjoyed our case review of the month. We've done 2 case reviews this month, and I hope that you join us for the next one. We're doing this at no charge. This is completely free. All we want to do is just share with you our experiences. And if you have any questions, please make sure that you email me at romerodentalseminars@gmail.com. If you have any comments, if you have any topics that you'd like us to bring up to the table, please let us know. Just sending us an email. And don't forget to subscribe to our channel. And most importantly, to share our videos. Thank you very much, and have a great rest of your day.